change your opinion. Who would go for Iris Claw? Still the same few number. So I won the battle. Who would go for the Yemeni technique? Fewer. So I'm talking about sutureless scleral fixated IOL. Scleral fixated IOL, under this entity, you might have sutureless and sutured. I'm talking about sutureless scleral fixated IOL. So, Doctor, what's your opinion on this?
We have not tried at a very young age. We usually prefer to do these above 6 or 8 years of age, both scleral fixated and the iris claw. Younger age, if there is a minimal support, which if we have a small support, we do a technique called as iris sutured IOL. Like we put one part of the lens in the remaining bag, and the other part is sutured to the iris. That is what we practice. Otherwise, we just wait until the child
Just
grows.
wait. So our study mentioned that the Yemeni technique is suitable for ages down to 3 years old. What do you think, Dr. Dominique?
So thank you for presenting the technique, because it's a very smart and elegant technique.
Thank you.
And I really appreciate. By the way, I prefer Iris Claw, but I didn't try your technique, so probably maybe different. I really think that Iris Claw is probably quicker, but it's not just the time we have to put for implanting. I think we maybe have the problem is probably also about infection. What do you think about infection, about those haptics that are?
Yes. I was very concerned with this in my study, but in the 26th child, I kept seeing the bulb or the flanges under the conjunctiva without any risk of extrusion or infection. So I was very concerned about this point, because I insist to see the bulb and to see the haptics, the flange of the haptics under the conjunctiva. So because I always scared of having the refractive surprise and to need to change the IOL after many years or few years.
Okay, that's nice too. And the other point is also we are dealing with children that are in a normal life. And I had just one child with an Iris Claw, and he just received twice a balloon in the eye. So, of course, there was a dislocation for that. So, I'm also, it was dislocated in the anterior chamber. So, of course, it's also another risk with sutureless, not scleral fixated, but in this also when dislocated for the. We'll see. So, Ibag, what's your thinking about that?
So I can say that Dr. Dominique changed her opinion, so I won the battle.
Just, I think both the techniques are very good, especially the MNAs, that elegant technique is good. But in children, one thing we need to always remember is if there is a FBN1 mutation, Marfan's related, better to stay away from the sclera as much as possible. So that's the most common cause of ectopia lentis in children. So there I will tilt towards more of iris fixation. But in patients with other reasons, probably traumatic, homocysteine, I think MNAs also is a very, very good technique. So, but one more thing, the sutured one is more riskier in Marfan's than MNA's technique. So that's something I wanted to add. Thank you. They will have a scleral problem. It's a connective tissue problem. Eventually, there are a lot of studies are there. The scleral sutured fixation will fall. They do not have an iris problem. So iris atrophy leading to dislocation is very less. This is specific to Marfan syndrome. So before we put a technique, we need to know the etiology of ectopia. Basically, if you have a molecular diagnosis, it makes our life much easier. in deciding the technique, along with just the surgical technique. But MNS is something very, very elegant because there is no suture involved. It's a track by itself. You take care of that. I think it's a very good technique.
Thank you, Dr. Omar. Thanks for all the speakers in the panel. Thanks for the attendees. May I invite the speakers, and thanks for the WSPOF, the Royal Society, for this very nice session. May I invite the speakers to take a photo? Okay, thank you.